Lovely.
Okay, welcome everyone. So we can get started since we have an hour. The Saving Mothers team would like to thank you all for joining us tonight for our first speaker series event this year titled Building and Rebuilding Trust in Healthcare. We are happy to have two amazing guest speakers with us tonight. For those of you that are not familiar with Saving Mothers, we are a nonprofit founded in 2009 that believes that no one should die while giving life. Saving Mothers is dedicated to eradicating preventable maternal deaths and birth-related complications in low resource settings. And we currently have programs in Kenya, Guatemala, the Dominican Republic, and New York City. As a reminder, if anyone has questions, we'll have time for questions at the end. So please put them in the Q&A section and we will remind you later about that. I will introduce you to our moderator, Dr. Taraneh Shirazian, and then she will introduce our guest speakers tonight. Dr. Taraneh Shirazian is the president and founder of Saving Mothers. She is a practicing gynecological surgeon and associate professor at NYU Langone Medical Center in New York City, as well as the director of Global Women's Health. She received her MD at the accelerated program at Brown University and completed her residency at Mount Sinai Medical Center in New York City. She is an international leader in global women's health and is frequently called on by national media outlets to appear as an expert in this field. She is also an accomplished researcher focused on interventions designed to decrease maternal morbidity and mortality, and her work has been published in many prominent medical journals, including the American Journal of Perinatology and ACOG Today. I will pass it over to you, Dr. Shirazian. Thank you.
Thank you so much, Dana. I want to first give a shout out to Dana. Dana Peters is our Saving Mothers Medical Fellow for the year. And she actually put together, along with our team at Saving Mothers on our executive board, two of our board members put together this amazing panel. I'm so excited to be here. And I'm so excited to welcome Dr. Diana Grigsby-Toussaint. I hope I'm pronouncing that correctly, Dr. Toussaint, and Dr. Julian Watkins to discuss this very important issue of building and rebuilding trust in healthcare. And as a provider of women's healthcare, as an OBGYN, I think about equity in healthcare regularly, and we've actually had a number of talks even at my medical institution regarding this topic. So I'm so excited to have you both and have your wonderful expertise and really be able to learn from you and discuss these issues with the group tonight. So first, I'd like to introduce Dr. Diana Grigsby-Toussaint. She is an associate professor of behavioral and social sciences and epidemiology at the Brown University School of Public Health. And as you already heard, Brown is very close to my heart. I do love Brown, the institution, and spent a few years there in Providence and just think so highly of the institution. She is a social epidemiologist, and in her research, she seeks to capture complex processes in the food, social, and built environments to facilitate a better understanding of their influence on what has been coined the 3 pillars of health: diet, physical activity, and sleep. So she has a number of interests in her research, and she actually has been supported by the National Institutes of Health. Her research has been supported by Robert Wood Johnson Foundation, the United States Department of Agriculture, and the National Science Foundation. And her work has been featured in the Huffington Post, the Dallas Morning News, and the Chicago Tribune, among others. I'm sure that Dr. Grigsby-Toussaint will detail all of the fascinating work that she's been doing. I'm going to give each speaker some time actually to introduce their passions and their research as well, because I can only give kind of a sliver, but we're so excited to have her today. Next is Dr. Julian Watkins. He's an internal medicine physician and public servant with a focus on community health and health justice. He's a culture of health leader in the 5th cohort of the National Leadership Program supported by the Robert Wood Johnson Foundation. I would love to hear more about that. I'm sure we'll probably get to that in our talk today. And this fosters collaboration between people from all fields and professions that have an influence on people's health to build just and thriving communities. He works at the New York City Department of Health and Mental Hygiene as a senior clinical advisor for the City of New York's COVID-19 emergency response. And certainly COVID has shaped a lot of public health discussion and a lot of our priorities, these days, and has highlighted significantly the equities in health that we see regularly. So I'm looking forward to also discussing COVID-19 in the context of our discussion tonight. That's our fabulous speaker panel.
Thank you.
Dana, should I launch in, or do you want to talk a little bit about the background?
I thought you could go into the background and then we can let our speakers talk a little bit about themselves, or we could vice versa do that, and then go into the background and then go into our questions.
Okay, well, actually, let each of our speakers introduce themselves now, and you guys can talk a little bit about your passion as it relates to building and rebuilding trust and sort of what you've learned in your careers and all of the work that you currently do that highlights, the topic at hand tonight. Dr. Grigsby-Toussaint, we could start with you, please.
Well, so thank you again so much for having me. And I think thank you for the wonderful introduction as well. I know that we want to get on to the rest of the conversation this evening, but one of the reasons I'm really excited about public health as a discipline, one, because it's so highly relevant right now. We see the importance in terms of our approach to COVID-19 and the things that have been illuminated as a consequence of the pandemic, where we see health disparities that clearly we haven't addressed, and which is why we're seeing certain groups being so disproportionately impacted by the pandemic. And so I really see myself as a social epidemiologist. My background, I've done some work in maternal childhood epidemiology, but very interested in looking at how, what are the social and environmental factors that influence health outcomes. And one of the reasons for this is I think that sometimes we forget that your health status starts before you go to the doctor. It starts way before you have a symptom, whatever that symptom may be. And for me, it was really important to be able to think about what are some ways that I can study and really articulate how social factors are influencing what we are seeing when people do get to the doctor. Because by then, one of the key factors of public health as well is that we want to make sure we take preventive measures. And so I think one of the key things for me was really being able to think about, if I'm telling someone that I want them to eat more healthfully, for example, I really need to think about, can they afford it? Can they afford healthier food? Do they have access to it? And if they don't, why might that be the case? Or if I'm telling someone that, I want to make sure that you're thinking about, I want to make sure that you can breastfeed your child, for example. Have I really thought about what some of the barriers might be to breastfeeding? What might be some issues around where that person works? Is it even possible? Do they even have time to be able to breastfeed? Can they afford a breast pump? So for me, I'm really very, very much interested in looking at what are these social factors that influence why we see some of the health outcomes that we do. And I think that really thinking about how we collect information to show these mechanisms and how we also work to ensure policy so that we can truly have an impact. And I'll stop there.
Thank you. Thank you so much. Dr. Watkins?
Yeah, thank you for the introduction. I think it's really lovely to see all the public health support that the Robert Wood Johnson Foundation is providing, that both of the folks on the call on this conversation have been supported by the program. And, I applied for this, it's like a fellowship program before the pandemic started, just for my work in the Bureau of STI control, dealing with basically the last major pandemic that hit New York City. And really trying to mitigate that and really highlighting the fact that, it's almost like, that old George Bush, like mission accomplished sign that people are like ending HIV by 2020. When you look at rates of HIV infection in New York City, 2019, 86% of folks who got HIV were Black and brown, 91% of women living with HIV, getting infected with HIV are Black and brown. And just seeing how 40 years, this year makes 40 years since the first HIV diagnosis in the United States, and seeing how that has played out in our city, in New York City, this bastion of liberal society, and how, people can be marginalized by, these innocuous policies, and how things can happen. And so throughout my work in the pandemic, I really was able to kind of shift. It's almost like a paradigm shift in the way I see the work of public health, because it was made so apparent, so like painstakingly, like painfully clear, the limits of our practice. The scope of our practice is so like Eurocentric, so classist, so heteronormative, so able-bodied, focused. And it's like the limits are there, and seeing how over and over again it's like failure after failure for group after group. And it literally just feels like this, like that Einstein quote where, insanity is doing the same thing over again, thinking you're going to get a different result. And it really just highlighted that for this unconventional time, we need new standards. So it's really, using this time as, using this time to kind of see what can we do and imagine a new way to practice public health as a public health practitioner, as a physician, using the lessons of the past to not repeat those, and really build a new way to see and do public health. Because this, again, a lot of my work is based in HIV care, but it's just highlighted how much the world changed after the HIV crisis began. And I think it's a disaster, but at the same time, it's such a great opportunity for us as practitioners and people who are involved in health to really have these kind of conversations and consider the impact of the work that we do, how we report it, how we do it, how we engage with communities. So that's kind of like, that's what brings me to this point in my career and to this call.
Excellent. Thank you so much, Dr. Watkins. I'm so glad actually that you brought that up, because I feel, and we can talk about this more over the course of the hour, but there have been sort of many parallels between sort of the HIV crisis and COVID-19 as, as a new sort of emerging infectious disease, if you will, that people didn't really well understand, and sort of what are some of those analogies. And then also the fact that, I personally do a lot of global work. And so the idea of access, to things like vaccine, or historically to medications, and, what that really means in terms of the future, and even in terms of the future of COVID-19. So anyway, I look forward to that. I think it's fascinating, and I'd love to hear more and to hear your perspective. So we're going to talk tonight about the historical injustices against communities of color by the healthcare system specifically. I feel like we can talk about so many things, but we want to try and just hit a few points that we think, are especially important for us at Saving Mothers, and issues that we deal with pretty regularly as well. And these historical injustices are fueled by racial bias. It's led to an erosion of trust and an alarming healthcare disparity that we see today. The COVID-19 pandemic has spotlighted the issue and brought it front and center. So it really has just highlighted injustices that have existed for a long time. And I think it's really important to kind of put it in that historical perspective, because I think there are many people who feel like, oh, these are new issues. These are, things that weren't happening before that now are. So I think that historical perspective is really important. In leading this conversation tonight, I will lean into my global experience in fighting disparities, specifically in maternal health care, because that's really my area of focus, and maternal mortality. As we see it here in New York City, specifically, where racial disparity, where Black women die at a rate of, by some estimates, as much as 12 times the rate of white women, and where these inequities exist not only here in New York City, but across the US and across the world. And we'd like to create dialogue with our guests around the need for rebuilding trust within these communities, which is actually, trust in healthcare is a big topic today. And I feel like, again, COVID-19 has only highlighted this concept of trust in healthcare. So the first set of questions is around acknowledging historical injustice, the impact on vulnerable populations that have created distrust, and how they are still happening. So I wondered if either of you, and we can just kind of pass the baton back and forth, but if anyone would like to comment on just the historical injustice, like the fact that these injustices, whether they be in maternal mortality or in other sort of healthcare issues, what are these disparities in healthcare specifically? What are the things that we've historically seen that still happen now?
Well, I can go ahead since Julian was the last to speak.
Yes.
As I was thinking about this, I teach a course every semester. Well, I actually started to teach a course for the first time this semester that focused specifically on race and health. And one of the first exercises I had was to have the students watch a video called The Power to Heal. And it basically told the story of Lyndon Johnson essentially using Medicare to be able to desegregate hospitals. And prior to that, what was happening was that you had many African Americans that were being turned away from many hospitals because they wouldn't treat African American people at those hospitals, and where you had many times people would be taken to the hospital in a hearse, it would double as an ambulance because sometimes it would be so late when you could find care that people would pass. And what's fascinating to me was that many of the students were stunned that there was this history in the US, with the healthcare system, that there was, these very different, there were two healthcare systems essentially. I think people really have heard about desegregation efforts around education, but not as much around hospitals. And what was really important too was they were really stunned that many facilities at the time before desegregation would have, for example, in facilities for African Americans, we have people with multiple conditions in the same ward. So if you had cancer, if you had heart disease, if you were having a baby, everyone was sort of relegated to the same area. There were African American physicians that had a difficult time finding places, hospitals that would take their patients. And so although the hospitals were desegregated, the problem fundamentally is that the issue of racism, and in terms of how African Americans were treated and viewed, was not fundamentally addressed. So the hospitals may have become, healthcare might have become desegregated, but the truth is the attitudes, the ways that the African Americans were treated was not addressed. So as a consequence, it isn't a surprise that now we have COVID-19 and we see that, we have a healthcare system where, as you alluded to, we see a persistent problem of maternal mortality, of disparities in maternal mortality that have persisted for at least 100 years between African American women and white women in the US. And so for me, so one, just in terms of the healthcare system, and because that hasn't been addressed, this is why we have, this year, I don't know if people are aware of this, but the Journal of the American Medical Association actually had a podcast that says structural racism does not exist in medicine. And I actually had my class respond to this, and they were really surprised. Well, how can people think this is the case? And so I think part of the problem is that we haven't fundamentally thought about how African Americans, other minoritized groups have been treated or are treated. And so that seeps into what we see in the healthcare system, and in terms of what we see with respect to disparities. Because we know the history of the Tuskegee syphilis, of Tuskegee. We know that we still are dealing with issues around implicit bias in healthcare, and we're still fighting in terms of advocating to deal with this intractable issue of the disparities in adverse birth, maternal and birth outcomes, especially with African American women. So I think that fundamentally, the sort of the window dressing, in the sense that you had desegregation of healthcare. But before you had that desegregation, African Americans were not treated in a way that their health needs were important. They were not receiving, care that was characterized by empathy. So simply desegregating hospitals and saying, well, now, it's open for people to receive care, didn't deal with this fundamental issue. And so this is why I believe we still see these issues with respect to disparities in care. We see issues with respect to, many African American women talking about how they're dismissed. We see studies, studies that go back to the 80s that talk about issues in terms of dismissive attitudes with respect to pain. There was a study, I think in 2016, where you had medical residents believing that fundamentally Blacks actually don't feel pain in the same way that whites do, or that Blacks have thicker skin. So a lot of these attitudes have continued to perpetuate how people are treated within the healthcare system. And I think until we sit down, have a conversation, I think the COVID-19 pandemic has forced us to have conversations around this and think about it. But I think fundamentally, we haven't really addressed that issue. And this is why this distrust continues today, and why we continue to see the disparities.
Thank you. Dr. Watkins, do you have anything to add on that point?
Yeah, I mean, I would say, this country does a lot of things well. And I think one of the main things that it does well is give the appearance of change without actually changing. And I think the thing that Dr. Grigsby-Toussaint was speaking of, to dig even deeper, it's like there's this original sin, right? The fact that dehumanization for the purposes of profit or the feelings of safety is okay. If it's for certain groups, it's okay and it's necessary. You look at how it kind of plays itself out. You look at the you look at the HIV pandemic, for example. Those people deserved what they got. There are a lot of parallels between, there was a president at the time who didn't even utter the letters AIDS in public for more than 3 years. And you see the comparison to what we're dealing with now. You go back further and you look at these desegregated, quote unquote, desegregated hospital systems, but the only reason they were desegregated was so that they could get money. They didn't desegregate their minds. They didn't desegregate their practice. And you look at all the disparities across the board, and it's the same story over and over again, and it's just like certain people, it's okay. Somehow it's acceptable that these things are happening to certain people, certain groups. And people can look at it with an indifference and without a humanity, but we can study it, we can quantify it, we can write it in journals, we can all of that, but there's no urgency to actually save the actual humans who are living under these conditions, who are dying at rates that will be unacceptable if the tables were flipped. And so it's an understanding of that, as intelligent as we pride ourselves in being, and as we can do all of these amazing surgeries, microsurgeries, how we can treat things, and we can understand and decode the human genome, that we can develop a vaccine so quick, that's so effective, we can make billions of doses, but we can't even have an intelligent conversation about these racial differences. We have these smart people who would go on a podcast and say that systemic racism doesn't exist in medicine. We have people who can't understand that people live intersectional lives, can't understand that someone may have a different experience than you, and that could be true. We have people who see trans people and segregate them from bathrooms, segregate them from healthcare. It's happening right before our eyes, and we can't even call that for what that is. And I think that kind of gets to that deep thing that this moment is asking all of us to do. It's asking us to really think about these things that we see all the time, and the things that we accept for okay, or that's just the way it is, because racism and all these things are not a force of nature. It's not like a tornado or a hurricane. This is actually by actions. This is policy. This is will. These are beliefs held by people. And I think that's how we see how it's still happening, because people refuse to look at it for whatever reason. Because maybe if they look into that mirror and look into themselves and really try to get to the root of these racial problems, they're probably scared of what they'd see.
Yeah, let's talk about that a little more, because I think that social determinants of health, we throw that around a lot, right? But that, and I know I'm kind of skipping out of order, but I feel like that this kind of lends itself to that. So social determinants of health really determine a lot of what we consider access to healthcare. So to go back to your point here, right? If the issue is that you have two hospitals, right? And right next to each other, even, let's say, geographically, they're located in the same place, but one offers microsurgery and only sees patients with insurance, right? And the other one right next to it doesn't have any of those resources and only sees Medicaid patients, let's say. So this discrepancy or disparity in the hospitals themselves and in the healthcare systems themselves, where people can access care, is also at the root, I think, of a lot of the health disparity that exists. So let's talk about social determinants of health. How do you think those social determinants of health, let's talk about what they are and how do they impact what we see in terms of health disparity?
Is that for me or Dr. Grigsby-Toussaint?
We can start with you, Dr. Watkins.
Yeah, I mean, that's a framework to look at it, to kind of look at the different aspects of our lives and kind of understand the different factors, and just understanding that. I mean, I think for me, I try to go deeper to this marginalization looking at what marginalization does, because if people are being marginalized, their needs and their rights to life and health, are being marginalized across the board. It's access to healthy food, it's access to a living wage, it's access to affordable housing, it's access to healthcare to even get to the door. Then they get to the door, and then they're met with people who are supposed to be there, they go to the hospital looking for care, and they meet a judge and jury where people will say, you're just malingering, you just want to get, you just want morphine, and it's to the point where even someone like Serena Williams and Beyonce can almost be lost to maternal fetal mortality. And they're like, oh, well, it's just poor people. It's across the board. And it's like this thing where people they cannot like deal with this core thing, I mean, it's almost like a core flaw of this society, where there's like, it's okay for those people to not be okay. They literally are said, like, people go out into the streets this summer and say Black Lives Matter, and then you get a response. You get people who say, no, they don't, all lives matter. They can't even say the words. They'll say that it is a terrorist organization, right? And that's it, and we're gonna keep doing the cycle if public health practitioners, people within public health, don't look deeper into what we're talking about. You know, we're putting band-aids on a problem that is way bigger. You know, this malignancy in our society, in our hearts and minds, is so big. It's been going on for so long, and we have to root it out. We have to look at the new ways to even talk about it. Because if people can't even say that, if the bare minimum to say that Black Lives Matter is something that is so divisive, then where do we go from there?
Dr. Grigsby-Toussaint?
Well, so, I think for me, in terms of, just thinking about social determinants of health, whether that's universal pre-K, whether that's education, for example, where we've seen studies by economists showing that, the earlier, for example, the students that children have pre-K, just universal pre-K, the difference that makes in terms of their life trajectory, what that means in terms of, finishing high school, going to college. And of course, that means then better opportunities for employment. And of course, because we're in the US where your employment is tied to your healthcare, better options for at least having access to healthcare. When we think about, one of the things that I study is access to green space. And one of the things that we found, I think, I think the important thing is thinking through historically, what are some of the policies that have been put in place and how do we adjust them? So for example, I feel like one of the most critical social determinants of health is, in the US context, is racial residential segregation. And the reason I believe that that's truly important is because, one, you had this homeowners loan corporation that 80 years ago designated neighborhoods as being, hazardous, or neighborhoods that were considered good neighborhoods. And most of those hazardous neighborhoods were neighborhoods that had African Americans. And so you look now, almost 80 years later, where you look at those neighborhoods that were, outside of gentrification, those neighborhoods that were labeled as hazardous have fewer resources. You have people suffering for example, from heat island effect because they have no coverage. So, it's really warm, people are uncomfortable. You have limited resources in terms of access to food. You have limited resources in terms of investment, with respect to, stores, with respect to economic investment. So for me, I really see racial residential segregation as being so critical, because where you live, we're starting to find that your zip code is really, really important, far more important than even your genetic code. So where you live determines what kind of school you go to. Not everyone can afford a private school. So what kinds of resources do you have in a public school if you have homes that don't have a lot of value? So what does that do? That's setting you up for going, not thriving in the long term. That's setting you up for not having the connections to allow you to be able to maybe get a job. So I really think that when we think about social determinants of health, the reason I say racial residential segregation is so critical is because it impacts so many other aspects of social determinants. So whether that means access to food, access to employment, for example, just access to an environment, recreational spaces. I think that all of those aspects are really critical. One of the things that we've seen through the pandemic is, people were told, we want you to stay home. We want you to work remotely. But guess what? Not everyone had the space to actually work remotely. Maybe you're living in a 2-bedroom apartment and maybe there's 6 people or 8 people living in that apartment. So where do you find the space to work? Or students, many school districts had to work remotely. Students had to go to school remotely. But one, the people have a computer. If you have more than one kid, what does that mean? Do you even have one computer? Do you have Wi-Fi as well? So do you even have a space to be able to say, I'm going to sit down and learn? So what does that mean? That means that we will then see a lot of disparities in terms of education. By next, I'm pretty sure we'll start to see this long term, in terms of this being a lost year for many children. So I really do feel that in terms of social determinants, really thinking about these other aspects of health that are critical, as I said before you get to the doctor's office. One thing that I am excited to see is that, for example, places like Kaiser, even here at Brown, are doing more when people come in to really think about how can we collect information on these social determinants of health and how can we adjust them. So getting information about food insecurity, finding out, have you had trouble paying your electric bill in the last month? So I'm really happy to see that I've seen partnerships, for example, at a medical school in Massachusetts, working with legal aid, for example, to see, well, how can we work with legal aid, because housing is an issue. We can tell people we want them to take their medication, we want them to do, we want them to exercise, we want to do all these things, but can they really do that if they're at risk of being evicted? So let's see how we can, bring in the law. So, bring in, law to work together. So I really think I'm really excited that we are doing more. There's more of a recognition of these social determinants of health. And I really do think one of the most exciting things I saw in the last day, and I feel so bad because I don't remember the doctor's name, where she was actually working with her patients to help them file the earned income tax credit. Many people didn't know that they even qualified. So one service she had as a physician was even asking them, have you filed this? Many people said, I don't think I qualify. And so she actually made space in her practice because she knew that thinking about these, the financial issues were also really important in terms of making sure that her patients were healthy, that they would listen to her advice. And so that was one thing that she did in the doctor's office. So I really think that people are thinking about more innovative ways of addressing these social determinants of health and really understanding that we need to think about creative ways. We can't address everything, but what are some things that we can do to think about what are some of those other broader societal issues that might be going on that are really important to allow us to make sure that patients are listening to physicians' advice.
Excellent. Thank you so much. That was such a great example, actually, because I agree. I think talking about the issues is one thing, but I think sort of really thinking about solutions is another. And the solutions are often not easy. They're complicated solutions. So how can we be creative in thinking about both how healthcare systems can be more accountable, how even doctors can be more accountable, right? How can we as a society make sure that healthcare equity is something that every person can obtain, and how can we facilitate that? So I love that example because, addressing some of the other social determinants at a doctor's visit, could really make a difference and made a difference in the lives of those patients. So are there any other examples like that? Do we have any other, when you guys think about, what solutions are needed, how do we go about finding solutions to this concept of rebuilding trust in healthcare systems and really of health equity, because that's what rebuilding trust means, of actually being able to get every patient the type of healthcare that they need and deserve. So how do we think about solutions, Dr. Watkins? Are there any examples of things that we should be thinking about or executing?
Yeah, I would say we had a really good example of like a case study in what like systemic marginalization looks like, right? Like we had a vaccine program that started in December, went over the last few months, and now we're like at the 6-month mark right now. And we can see what were the results. In New York City, there's discrepancies of over 300,000 folks in highly diverse, marginalized people with low uptake of the vaccine. There's a gap of that much, And now that we've shifted, we transitioned to this point in vaccines where it's like, okay, we need to figure out a way how to get these folks vaccinated, because there's this gap. Like, how do we make up this gap, you know? And so in, you know, a lot of my current work in the health department is like, well, with the way, it's the way we talk to people, you know? It's about the narratives that we build and we tell ourselves, you know? It's like moving from those people are vaccine hesitant, or just calling them vaccine hesitant, labeling them, pathologizing them, and not using people first language, not using a broader scope, a more humanistic, a more, you know, whole person approach to understand that these are people who come from a very particular experience. And you look at the world around them, you look at what's been going on, you're like, do those people really have a reason to have any confidence in us, in the system? You know, when we, in many circumstances, have been the ones who kind of like perpetuated some of the trauma, you know, the healthcare system, looking at what happened in the pandemic, you know, hospitals in Queens, people were dying at rates higher than those in Manhattan that were resourced, you know? And so when we have this conversation about how can we go forward, I like to say, you know, I like to move the conversation from, you know, people first, but then I was in a public health, in a meeting with a community group, and someone was like, you guys have a messaging problem, you know, like you guys don't sell the vaccine right, you're not giving to them right, people don't see it. And I heard that, and it feels like that's not it. We have an integrity problem. Healthcare, public health, research, all across the board, we have an integrity problem, you know, and people are questioning our integrity, you know, and the examples and the solutions are, what can we do to prove ourselves trustworthy, right? It's a commitment to do right, it's a commitment to change, there's an acknowledgement, and all of those are steps, you know. And it's like, if you ask for forgiveness, there's like forgiveness, but don't do it again, right? So let's learn from this and let's move forward. Let's build a better healthcare system. Let's talk about how we can include communities, you know? Let's talk about how we can get resources to people, food in mouths, you know, roofs over heads, heat, all of these things that are always forgotten because, you know, there's the one primary objective, you know, get all the vaccines, but like people have other needs too, you know. People are worried about, you know, getting food on the table for their kids, you know. And it's just, these are the things that we have to do, and it's about moving beyond our discomfort with some of these uncomfortable topics and being, you know, and being racially specific, you know, because not too long ago, and even right now, like we live in many aspects of our lives are segregated, you know, and the only way you can undo some of that damage is to do the opposite, right? Look up anti-racist practices to kind of break down these power structures. Look up racially specific interventions that are directed at the people who have been marginalized by the active process of marginalization. Didn't just happen. People were doing it to them, you know? These communities were made vulnerable. They didn't just, you're not just vulnerable because you're just born Black, you're vulnerable because the society is doing these things. All these social determinants of health are being affected by the society, you know? And so there are these concrete things that can be done. I think people just need the will to kind of really accept and acknowledge and face up. Like we were born and we, you know, we're trained into these systems. We didn't create them, but we're maintaining them. And at some point, we have to take that responsibility as the practitioners and say, look, enough is enough. You know, how can we do it in a different way? How can we do it in the right way? How can we show a commitment to doing this the right way? I would love to see at the end of this crisis, all of these conversations that we're having, that people can actually like apply it. I don't want healthcare to look anything like it looked like before COVID-19 pandemic, because the way it was, like you saw what the pandemic did, how it just, you know, almost demolished so many of these communities across, like that wasn't it. That system was way too fractured, was not supported, was way too sectioned off, segregated. And it's like, we can't go back to that. We have to imagine new ways. And there are concrete examples to do it. We just have to have the will. We have to like lean into that discomfort, because for those of us who do have, who are the gatekeepers and have the power, you know, we have to really think about that. Our discomfort is not more important than the lives that are affected by our inability to recognize some of these hard issues and have some of these hard conversations. And I think that's like a prime example of like looking at what happened with vaccines, what continues to happen, and really use that as a case study. And hopefully when it's all said and done and people can get vaccinated, then we can apply these lessons that we learned, apply all these conversations, and really investigate some of the other work that we do.
Yeah, excellent. It makes me think about like somehow cross collaborating. Here in New York, during the crisis, we set out to really address maternal mortality, but a lot of our women, they would email us, or when we would call them to find out how they were doing, the pregnant women, they would tell us, well, we can't get food, Dr. Shirazi, and like the food banks are closed, like there's no food. And so we moved from really thinking about teaching them health and teaching them about coming into the doctor to delivering food, because that's what was required. But, if it was I think some type of combined mission, and cross collaboration in some way, that like we haven't even fully explored, and addressing more than one social determinant at once, could be really effective. But yeah, I mean, that's the pandemic really taught me a lot about food insecurity. I mean, I was aware of it, but it was way more of an important issue than health, than seeing your doctor or anything. So,
I mean, I don't want to take up, but even we see these
Yeah.
images from the Great Depression.
Right.
You see food lines, bread lines.
I know.
I live in the Lower East Side, and there was a school right across the street from my house, and I would see people lined up down the block in the richest country in the world, in the richest city, in this country, and there were people who were struggling and waiting in line every day in the snow to get food.
Right.
And that's where people are, and that's the thing that we really have to grapple with. And it's that like whole people, entire people are walking in there, not just an organ system, not just a broken bone, like a whole person, with a whole history and a whole thing, a whole family that loves them, the whole person is there. It's whole person care.
Yeah, absolutely. All right. I could keep going, but are we supposed to be taking questions, Dana, or should I go a little bit more?
Have any questions right now? So
okay. Well, I want to talk about solutions a little more, because I actually had the opportunity to hear a really wonderful talk the other day. A young woman from UC Berkeley in the OBGYN department there, and she was saying that a lot of these issues with healthcare systems specifically has to do with, the funding of healthcare, the investment in hospitals, to make money, to be basically productive in terms of economics, right? To be economically viable and sustainable, but also to make money essentially as a business. And so, someone asked her the question, which I thought was so thought-provoking, that about democracy, and is like this democratic idea, not democracy, I'm sorry, capitalism, excuse me, is this idea of capitalism itself, is that racist? Is capitalism racist? Someone asked her that idea. And I never really thought about it like that, that this drive to sort of make hospitals, economically viable, that could somehow, be racist, or be have this underlying inequity, I think is really what the question was about, that's inherent to it. I don't know. So I just thought I would pose that to you guys and see what you thought about that, about this idea of capitalism and the business of medicine itself.
Dehumanizing,
definitely.
Yeah. Within capitalism, they used to own people like me.
Right.
That's how this country got, that's how you look at the Caribbean, you look at Latin America, you look at what that force did to this country, a country, a landmass that was filled with millions of people, and it was all for the pursuit of capital, for money. They actually turned human beings into capital, and it's like a thoroughfare throughout our history, where we can see people just for the work that they provide, where people can work their bones off, work 2 jobs and not be able to feed their children, not be able to live in a home, securely, where the average person, and like, I forget the percentage, where like most American families are one illness away from bankruptcy, and so like, yeah, like it's fundamentally at its core, this dehumanizing process.
We got a question. Sorry, Dr. Grigsby-Toussaint, I'll let you answer that, and then I think we have a question.
We do. Oh, we have a question?
Yes.
Okay, I'm trying.
But I'll let you answer. I'm not
Okay.
going to take away the answer. Yes. No, if you want to answer that question, and then I'll read the question in the chat.
Oh, I was trying to see if I could read the question.
Oh, no. I'll read you the question. But if you wanted to, I didn't want to cut you off if you wanted to address the last topic about capitalism, and I don't know. If you don't, we'll move on to the next question.
What? Oh, wow. We probably should be. I can't believe the time.
I'll read you this question. In New York City, in the past decade, there have been initiatives to integrate medical healthcare with social services, medical homes, but there doesn't seem to be much traction. Has it been undermined by anti-socialism movements, or fundamentally a money-making problem?
So I don't know much about New York City per se, but what I do find very interesting is that, like I said, this past semester, we had an opportunity to look at the history of race and racism and health in the US. And one thing that was fascinating was that as we were looking at old footage, we saw some of the same things that we've seen in terms of resistance towards the Affordable Care Act, where there were conversations and also from the American Medical Association, that, this was socialist, that, having Medicare, having these programs, was introducing socialism into healthcare. And that fundamentally went against sort of, the American, view. So I do think that part of the challenge has been, that there's this concern that if we try to do more with respect to thinking about the social determinants of health, that somehow that means that we're fundamentally changing the healthcare system. And it's unfortunate because I think people should understand that when you think about the World Health Organization definition of what health is, it isn't only the absence of disease, right? Is your mental health, is your physical health, is your emotional health. And because it's all those things, I think to Julian's point that he made that, we aren't just organs. And I don't think that people are really thinking about the fact that if we do think more about how to integrate these social aspects into health and really think about more innovative solutions, that we actually might have better outcomes. But I do think that the one positive thing that I can take out of the pandemic, because there's not much that's been positive that's come out of the pandemic, right? But I think the one thing is that people are talking about these issues more. People are really thinking about these disparities in medicine, really thinking more about how we need to think about the whole person, really thinking about, we can't just tell people we want them to do X, Y, Z. Let's really think about how do we work with our patients? How do we work with other organizations to think more about the other needs that people might have outside of just saying you have disease X or you have this condition. And so I'm going to prescribe medication and this is what I want you to do. So I do think that there, as Julian said earlier, there is more of a conversation that's happening. I think that the important thing is that first we acknowledge that there is an issue. And I think there are a lot of policies coming down the pipe. So we have the Black Momnibus Act of 2021 to focus on, issues around Black maternal health that really talks about, wants to address social determinants of health. really wants to think more about metrics related to, how are we really evaluating the care that women are getting. There are also places like California that are doing work in terms of passing legislation around dignity for childbirth that, stipulates that there should be training around implicit bias. There are places like Illinois, for example. There's also thinking about legislation related to, what are some of the additional rights outside, just patient rights when it comes to people getting maternal care. So whether that means that is culturally responsive care, for example, that people are receiving, whether that means that people are also treated with dignity in terms of their interactions, and that if they're not, then there's a penalty for that. Because I think one of the things too is that we can come up with these policies, but sometimes the only way that they're truly, that we can really enforce them is that, there has to be, if you don't do these things, then, this is sort of the penalty for it. So I think a great thing is that we're having this conversation, we're naming this, we are truly aware of what these issues are. At least we're starting to become more aware of these issues, because we wouldn't have had this whole no structural racism in medicine with that JAMA article if people were truly aware of what was going on. But I think we're having more conversations when we look at the most recent stimulus, for example. There's if it ever passes, but there's stipulations in there for for universal for preschool, for example, in preschool for kids. There's also a child tax credit. So I'm hoping that these policies that people are thinking more and more about, we need to implement these broader policies that will be impactful for everyone.
Yeah. Okay. And I think, one of the questions that I think is on everyone's mind and that everyone sort of wants to, at least at Saving Mothers, we get a lot too, is what can we do, like as an individual, right? What are the specific next steps that people can do? What are the specific next steps? Someone else is asking about who's a good mayoral candidate, So I think it's about what are these next steps that, the average person can take that can help us address these issues. And, and I agree with everything that's been said about physicians kind of taking ownership and really thinking about it. I personally would like to see some broader change in terms of like health systems, because I think, yes, the individual doctor can do certain things, but we're also limited. I think, we only see X number of people per day. We're going to be a little more limited than, like you were saying, a policy change or just a change in how the health system runs or operates. That would reach a lot of people potentially. So anyway, so what are some of the specific next steps you would advise people on? Like what can they do as individuals?
I'll say the first step is probably take a breath, because it's heavy, it's super heavy to see all the things happening, to see and learn about the disparities, to really think about how deep it is, how so many to realize that in many aspects we've been lied to, So just take that breath and just damn. And then the next step is like, okay, what do we want to do, right? The world is changing all around us all the time. The rules of engagement, reality is always shifting. You asked a year and a half ago if we would be in this place now, living on Zoom, not seeing family members for as long as we have it, seeing 33,000 people die in our city unexpectedly from some new virus, but but the rules are changing all the time, and I think it's up but we can, just as they can change for the negative, they can also change for the good, and it's with people taking the will to take that daily commitment that I want to do better, I want to live my life, in a way where I want to be in community, where I think about the other person, where I think about the earth, where I care for children, I treat animals well. It's a commitment to daily to doing that work of like living with like a love kind of emotion, like a love ethic, you know, where it's not just about me, you know, where it's beyond just the self, the individual, and it's more broad, you know. It's like, it's a multitude. I am not just myself. I'm a family, you know, I'm my family. I'm my ancestors. I'm the people coming after me, you know, and it's like living a commitment to that. And it's daily, right? What's my daily practice? What's the daily good that I want to do? You know, what's the, you know, what do I want to put out in the world? It's finding something and doing something. We all have a place in this. And some people can move mountains and some people can do all of that. But some people, it's just, you know, donating. It's a commitment to doing that good and putting that good out there. And just imagine if so many people around the world were committed to doing good and committed to community and committed to making this world a better place, committed to justice and love, you know, we could do it. And it's just like that daily, like, what am I going to do today to help somebody out? Yeah, and it's a little bit of an engagement because it matters. It may not matter. All the things matter. Voting matters. All the things matter. And just being a little bit engaged, you know, with the discourse, like what is going on. I know who I don't want to vote. You know, who I don't want to be the mayor. You know, I know who I'd rather not be the president. You know, I know what policies are going on. Where it's like I want to help that not happen. You know, we've abolished slavery. We can abolish police. Like, you know, the prison industry. We can abolish things. We've abolished things that before they were abolished, people were like, I could never imagine a world without that. We can do so much. We can move so far ahead. And it starts with that daily commitment in yourself, the personal revolution. Because the big one, it ain't gonna be, you know, storming the Capitol or well, it's not gonna be all that. It's a personal revolution, you know?
Yeah.
Well, oh, sorry. Well, for me, I think just in terms of, you know, steps, one, I'm really happy that Saving Mothers is having this conversation, that you felt this was important, that this conversation was important to have, and that you have this series, because I think one critical thing is being able to use our platforms, whatever platforms we have, to have these discussions. We know that misinformation has played a critical role in this pandemic. And so there are people that are using platforms that are making a lot of our lives very difficult in terms of public health. So I do think one of the first things is, one, using the platform, engaging in these conversations. I think also, you know, really thinking about what we call, I think it's Angela Blackwell, I think, who she calls it the curb cut effect. So I believe in the 1970s in Berkeley, California, disability advocates decided that they needed the curb, you know, on the sidewalk cut so that it would be easier for people to move their wheelchairs. But it turns out that that was a benefit for people who were pushing their strollers. You know, it was a benefit for people who were biking. So I think also thinking about solutions that, you know, that can, you know, we may think about one particular group, but really understanding that there are benefits to so many other groups. So when we think about this child tax credit, of course, there's, you know, differences in terms of how much of the credit people get in terms of their income. But in the end, everyone benefits. But the most critical thing is that there have been estimates showing that so many people will be lifted out of poverty. I think really thinking about looking at countries that, you know, that have a lot better gender parity than we do. Places like Finland, for example, where there's a lot more with respect to, you know, paid leave for parents. You know, again, if there was paid leave, we wouldn't have these high numbers in terms of people who are filing for unemployment. You know, so I really think that thinking, one, using whatever platform we have, depending on whatever our specific careers might be. I really think that that's one thing to do, is really think about how we engage people, how we continue to have these conversations, and really thinking more about broader policy solutions, because those ones are the ones that tend to have the biggest bang for the buck.
Yeah. Well, thank you both so much. I am over time and I want to be cognizant of your time in the evening. I'm sure you have many things to do and families, and I know no one's probably eaten dinner even. But thank you so much. This was such an amazing talk. I really feel like it spotlighted a lot of the issues around trust in healthcare systems. You both brought up many wonderful points about how we should think about solutions and specific solutions. And I think really all of us can be part of the solution, which has always been our goal at Saving Mothers, to help not only, create some of these programmatic solutions, but also just hopefully inspire others, inspire our young students, our chapters. I'm always amazed at the future generation of public health leaders, physician leaders. And so I know that these solutions exist, and I know that together we can forge a more, equitable path forward for everyone. I know that we will achieve it. I just hope it's sooner rather than later. But thank you so much. Thank you. And thank you everyone for joining. If you have other questions, you can email us. Here's the email that Dana put up, information at Saving Mothers. You can visit us at savingmothers.org. But please, any lingering questions, we're happy to share with our fantastic panelists. And thank you all so much for coming.
Thank you for inviting me. Nice to meet you.
Thank you so much.
Yeah, thank you.
Good
Thank you for
night.
making this
Thank you
space.
for being so candid and personal
Yes.
issues.
I loved it. Thank you.